meeting. So first, I'm Will Myers. I am an intern with the Foster Family Alliance in North Carolina. And today we're joined by Gaile Osbourne, our executive director and board president. And also our guest is Christy Street. She's the program director for Fostering Health North Carolina. We all know that there's a lot of changes coming with Medicaid, and that affects our kids, whether they be in foster care, whether we adopted them for foster care. And so there's so much that changed on July 1st that we wanted to have a quick webinar or recording with a subject matter expert like Christy Street, who can answer some questions. And a couple of weeks ago, we put a post on our Facebook page and in the Facebook group for Foster Family Alliance. And we have a few questions, and then we're just going to have a talk with Miss Christy. That way we can, somewhat navigate these waters as they continue to change. It is important to note that these answers are for what is current right now. Things are ever changing, and as we go forward in the next couple of years, things will change. So this information may change in the future, but it is current as of this recording. So hi, Christy. Hi, Gaile. How are you guys?
Good morning. Doing well.
Good morning. I'm sitting outside of a therapy for my daughter right now, so apologize for being in the car.
Yeah, I mean, it's incredibly appropriate. We're talking about Medicaid and different things that are changing. It's just one of the many things that we do as foster parents is we have to work where we are. We don't necessarily get to always work in an office or a nursery. So
right. Well, and Will, I appreciate you getting this together because, I felt like we were getting lots of questions, and, here I am with 2 adopted children and a foster child in my home, and I don't even know what's going on. And I was having to find myself reaching out and getting answers, and it seemed like I could ask this person over here and I'd get one answer, and I'd ask this person, I'd get another answer. And so let's just go straight to someone who knows the answers and go from there. And so I think let's just turn it over to Christy and let Christy kind of just unpack the overall and the arching things as to how it's going to impact foster adoptive families in North Carolina.
Okay, great. Thank you, Will and Gaile. Hi, everybody. I'm Christy Street, as they mentioned. Just a little bit about who Fostering Health is. I don't work for Medicaid. I work with Medicaid a lot and with the Division of Social Services. And so anything that I don't know the answer to, I will figure it out and get that back to Will and Gaile so that they can pass that along. It is a complex system right now. As if the system wasn't complex enough, it's become even more complex. And so what we do at Fostering Health NC is to help with health and well-being issues related to children in DSS custody foster care. We're funded by the Division of Social Services, housed at the North Carolina Pediatric Society, and we meet with anybody that has anything to do with kids in foster care, primarily DSSs and primary care providers, but resource parents, any stakeholder that really is involved in the life. And so when Medicaid started to change, we were like, as long as we know what's going on, we're glad to be part of the speaker for that, because we are the ones that are reached out to and get some of these questions, and we want to know the answer so that we're not having to say, call an 800 number, if it's something that we can answer. So that's sort of the level setting of who I am and what my program does. So the brief nutshell of what's happening with Medicaid is historically, or at least the most recent future, we've had Medicaid run by the division, what used to be the Division of Medical Assistance is now Division of Health Benefits, or North Carolina Medicaid. And they have done the health, physical health side of things, the dental health side of things. And then we have the local management entities / managed care organizations, or LME-MCOs, that you guys are probably familiar with. There are 7 regions across the state that authorize the services for intellectual and developmental disabilities, as well as behavioral health care and substance use disorders. And so that system has been what's in play for most Medicaid recipients for years now. North Carolina has, because of some legislative things, has started moving towards a managed care system from a fee-for-service system. So historically, or the old system before July 1, so before last Thursday, Fee for service means a doctor does a service or a provider does a service, they bill for it, they're paid for it, generally speaking. What is happening now with managed care means that there is an allotted amount of money per member or per beneficiary, per child in the cases that we're talking about. And those services need to be within that amount of money. There are other ways, you know, for other authorizations, for things like that, if children need more. And a lot of people that receive Medicaid are changing to this managed care system, but some are not. Most of who we're going to talk about today that you either take care of as your foster children or have adopted through foster care, it does not apply to them in some instances. So making sure I'm getting my notes right. So the new system is back in probably January or February. Many people that receive Medicaid would have received a letter saying you need to choose a health plan, a prepaid health plan, or a health insurance company's all the same thing, to start in the standard plan, which is what started on July 1st. And that's for many people that receive Medicaid, non-foster children, so a lot of children, a lot of adults would need to enter the standard plan, those without complex behavioral health issues, generally speaking. But children in foster care, and this is there's a couple of things that are going to be really important. Children in foster care, and this is DSS custody foster care, on June 30th, up through June 30th, nothing should have changed. You may or may not have gotten a letter. Will and Gail and I were talking about whether they got a letter on their children. They did not. You may not have, it sounds like, but nothing should have changed. Probably not a new Medicaid card coming out if you have access to that. Their doctor should be able to stay the same. If their doctor took Medicaid before, they still take it, probably. And if they were receiving behavioral health services through a behavioral health agency, your LME-MCO, or the one applicable to the child, is who is authorizing that care. So that part shouldn't change. There are some populations, some in foster care, some not, who do have higher levels of behavioral health needs, and they are what are being considered tailored planned eligible. So in the future, there will be the standard plans, which started July 1st, and tailored plans. Tailored meaning they are tailored to the needs of higher levels of IDD and behavioral health issues. So they don't exist yet. They're doing this in a phase so that everybody in Medicaid doesn't just get dumped into all these different plans when this is such a big change that it would be even more confusing. But there are still those people that are tailored plan eligible that you don't want them in a standard plan because the standard plan doesn't interface with the LME-MCOs, and so they wouldn't be able to get those services. So respite services was an example that Gail and I talked about, and respite services are not available through a standard plan. So a child that has respite services would need to stay in Medicaid Direct, is what they're calling that. So foster children, as of or up to June 30th, should stay the same, which is fee-for-service Medicaid or Medicaid Direct, as well as children in foster care who may be tailored plan eligible. So on the back end, there's probably some coding things that are that have them designated as when the tailored plans start, that they would stay in for a tailored, or they would change to a tailored plan. So that's the important piece. Up to June 30th in foster care, nothing should change for their Medicaid. Starting July 1st, and sorry, I'm going to try to get these dates right so I don't confuse everybody. July 1st is when the standard plans came into effect. And generally speaking, it doesn't affect foster care. Those in foster care prior to go live is what they're calling it, go live. But who it does affect is those children that are not yet in foster care, who may enter foster care this month, next month, 6 months from now, who are in a standard plan. So we're going to have an example of Sally, is a child living in Wake County, for example. That's where I am. She lives with her biological family. August 15th, DSS has to take her into foster care. So all of that happens, how that happens. And she has a standard plan Medicaid because as of July 1st, she was not in foster care. And let's say she didn't meet the tailored plan eligible part. She hasn't gotten any mental health services yet. So she's in a standard plan. And there are 5 different ones of those. United Healthcare is one, Blue Cross, WellCare, Carolina Complete Health, and one more. Can't leave them out, AmeriHealth, Caritas. So let's say Sally has United Healthcare Medicaid. As of July 1st, that's what she got because her parents chose that or because she was auto-enrolled because a lot of people didn't make a choice because they missed the letter or whatever. So on August 15th, she comes into foster care. A form that DSS fills out with their Medicaid office starts the process to disenroll her, Sally, from United Health Medicaid and enroll her into Medicaid Direct, which is the type of Medicaid children that were in foster care already up to June 30th receive, where the state is in charge of the physical health piece. LME-MCOs are in charge of the behavioral health, IDD, and substance use disorder part. So her Medicaid doesn't change, her eligibility doesn't change, her none of that kind of stuff comes into play. It's a category changes. But what can change is the fact that she was in a standard plan and she was seeing her primary care provider. Let's say she was going to Raleigh Peds. That shouldn't change because if Raleigh Peds takes United Medicaid, then they take Medicaid Direct.
Correct.
Every doctor's office takes every one of those standard plans. They chose who to contract with. They can contract with all 5. They can contract with 1. But if they take any of those Medicaids, then they have to take Medicaid Direct because it's just part of the package of Medicaid. But that shouldn't have to change. If Sally came into care in Wake County and she is going to stay at Raleigh Peds because that's where her foster parents live near still or whatever, then that shouldn't have to change. What could change is, I think I had said she had not gotten any mental health services. Let's say she had. Let's say she had started some services. Well, starting in July 1st, when she went into the standard plan, those were being authorized through the standard plan or United. And those are more basic level behavioral health needs. So she hadn't been getting any kind of respite care. She wasn't in foster care yet. She had not been getting, she wasn't at a PRTF. She wasn't at, and there's a whole list, which we can get you guys the link to, of what qualifies for that tailored plan. So what could change is that wherever she was getting those services could have to change if they are not contracted with the LME-MCO that Sally is linked to now that she's switching to Medicaid Direct. She could also start to get a higher level of care if her diagnosis changes, if she gets a new diagnosis, because some diagnoses are only through that Medicaid Direct or LME-MCO part of things. So on the back end, DSS should be doing this form with their Medicaid office, which starts that process. It is retroactive. So we said Sally went into foster care August 15th. Her Medicaid Direct benefits retroact to August 1st. So things can go ahead and start rolling, even though new cards may not have been developed yet or those types of things. And the United or the health insurance company or prepaid health plan is what they're calling them, should be working with Community Care of North Carolina, who is going to be the care management entity for children in foster care, and already is actually for children in foster care, to make sure that those services are going to be figured out. They'll also be in contact with the LME-MCO if applicable. And in Sally's case, it was if she was getting any type of mental health services.
Christy, can I ask you a question right now?
Sure.
One of the concerns that we had as foster parents is that kids would come into care, and because they, let's say, I live out west and I would get a child from the central part of the state, and they would not necessarily you know, we were trying to make sure with this transformation that the kids would have access to the LME MCOs. You know, that was what we were excited about with this. But what I just heard from you was that that's not going to be in this first rollout. But in the second rollout, when the foster care plan, are we still going to be bound by the LME MCO areas when it comes to like services? Because, you know, like, and I'll just speak for my now adopted kids. They came from Alamance County, and we moved them into Buncombe County, and it was over 100 days to get services going. You know, it was incredibly frustrating. And so, you know, help me understand more about that.
Yeah, so if we think about how the plans are rolling out, you're right. So right now, that hasn't changed. So for foster children and those that enter foster care and go into Medicaid Direct and are getting their behavioral health services authorized through LME MCOs, that structure is the same. It's the 7, although there's been some changes, or there are changes coming soon to Via and Cardinal.
Yep.
Right, Cardinal. So maybe there will be 6, or maybe there are 6 if that's how they're considering, and I'm not an expert on that part of it. But so that part, July 1, 2021, so this year to June 30th, 2022, that stuff stays the same. So those frustrations can still be there, hopefully, and it takes everybody communicating about that to get. There should be able to be, if there's a service provider in the area, there should be able to be a single case agreement. If there's not a contract with the LME MCO from Alamance County, for example, in Buncombe County, they should be able to make that happen a bit sooner than, if that's the barrier, than 100 and some days, because they can make single case agreements to get that stuff happening. Sometimes it happens that, you know, you're in an area that doesn't have providers, or they have wait lists because there's not enough providers for everybody that needs it. And that's a bigger system problem, you know, than the single case agreements. But LME MCO should be able to work with counties that these kids move to. So the short answer is no.
But what's happening is the DSSs are holding on to the Medicaids within the counties that the kids originate. And so when you place a child outside of the county, that, you know, it stays within that LME where that county DSS is, and the kid may be, you know, 15, 16, 18 counties over.
Right.
And so there has to be that single case. And I'm just familiar with the ones where I live in Buncombe County, where we have plenty of service providers, except for like ABA, or, you know, something like that. And so what we're running into is they're not wanting to write the single case agreements, or they're, you know, they just have such wait lists that they don't need to do that. And so it's frustrating that, because my understanding was that this was going to eliminate that. So, I mean, clearly this is an advocacy point that we need to get back at the table with on this. You know, and I don't know how to fixate it. And, you know, I don't know how to fixate. I'm a little tired. I don't know how to fix this other than the money follows the child. Like that we do, the money follows the person with the IDD. You know, we've got to have these conversations, because, and I'm sure there'll be plenty of foster parents that'll agree with me, this is incredibly frustrating to have a child in their home, especially if it's a new intake or a big move, or, I mean, it's trauma, and you have a child that can't get services. And so go ahead.
Yeah, so I totally agree. That's what we hear from county to county, and from LME MCO catchment area to LME MCO catchment area. And I think what it takes is just continuing to lift up those issues to the LME MCO, to the DSS, to the Division of Mental Health, Intellectual Developmental Disabilities and Substance Use Services. They have a very long name, who, you know, oversee all of that. And So for July, so the system part won't change from July 1 of this year to June 30th of next year. What
Right.
will change after that? So July 1st, 2022 is when the tailored plan or tailored plans start. And so from what I'm understanding, and some of this is on the Medicaid end where they, the LME-MCOs that wanted to be one of the plans to run the tailored plans, they had to submit whatever they submit for the request for proposal and all that to see if they get the bid. And I don't know how many of them there can be. There's 7 now or 6. I don't know how many there will be once the tailored plans roll out. That's not determined yet. And so it will be, I guess it could be what it is now running the tailored plans, or it could be less than that. But those tailored plans will be for people with more complex behavioral health and IDD and substance use disorder services and needs. And so those plans will be in charge of whole body care for those individuals. So like now the standard plans are technically for that population that could be in standard plans, they are responsible for that. So in the standard plan, if a child needs, everybody needs a primary care provider, but let's say the child also needs some, outpatient therapy, then they could be in a standard plan, and the standard plan contracts with those providers. For the tailored plans, they're going to also be contracting with physical health providers and behavioral health providers. So to be more integrated, and so more to come on that as they figure out what plans, what LME-MCOs will get those plans, how many there will be, and those details. So some children in foster care next year, unless something changes, but this is the understanding I have right now, is that many children in foster care will just stay in Medicaid Direct because they're in foster care. Others that are tailored plan eligible will will go to a tailored plan because that Medicaid Direct won't have those services anymore because that tailored plan will be in play.
So, Christy, can I just do a quick recap to make sure I'm following? So it sounds like any child who was in care June 30th or before, everything's the same. If kids came into care at July 1st or now, they will revert back to the same plan that was there June 30th?
Yes, if they were in a standard plan, if they chose one or they were auto-enrolled in one.
Okay. What happens to kids who were not in a plan whatsoever? Maybe they had private health insurance. Would they revert right back to Medicaid Direct as well?
So if they were uninsured when they came into foster care, so had no insurance or had a commercial or private insurance through their bio parent, they should, when they enter foster care and that form is filled out by DSS, they should go straight into Medicaid Direct.
Okay.
What the other kids should be in that are in foster care. Because some children that come into foster care and have that private insurance through their parent keep it and some don't, depending on their parents' bio parent's job, and all that kind of stuff. But they shouldn't interface with a standard plan at all.
So it sounds like to me that at this juncture, no foster parents are going to be interfacing with the standard plan, right? They shouldn't be for their kids, right? Is that accurate? That everything, it should sound like in the background, a lot of stuff has changed, but for the parents who are kind of boots on ground dealing with this stuff day in and day out, things should be able to stay pretty much the same. Is that right?
Generally, yes. So those that had children in foster care up to June 30th, that should be able to be a blanket statement. We have heard from someone in a county that the child who has been in foster care since last year, nothing has changed with her foster care, somehow is enrolled in a standard plan. And that sounds like that should be few and far between. Mm-hmm. It sounds like a mistake was made somewhere. Either a mistake was made for someone choosing a standard plan or her being auto-enrolled in a standard plan because of who knows what. It could be that when she entered foster care, the category of Medicaid that she was assigned in the back end did not designate foster care as the type of Medicaid. And so all along, it hasn't been a problem because it hasn't mattered. But then when it was time to either be in a standard plan or not, she got lumped into a standard plan unbeknownst to anybody, because in the system, she looked like she was just a child living in her bio parents' care.
Right.
So there's a way to change that, and we've given instruction. And so that shouldn't affect resource parents or foster parents, but we all know everything does, right? So you guys, either you may not have a Medicaid card, or you may not, be the one doing the paperwork on the back end. It affects all of you because you're the ones taking them to the doctor. So you're the ones that are going to hear from the doctor, maybe that, oh, that child should have this kind of Medicaid or whatever, if there are glitches. And then there could be that those kids that enter foster care after July 1 that were in a standard plan, or that are in a standard plan and are going to transition to Medicaid Direct, there could be some interfacing with something to do with the standard plan. So the example I can think of, I don't think that foster parents would be interfacing with United or with Blue Cross Medicaid. But what could happen is the child could be receiving care management. So care management is a big part of Medicaid in general, but especially as we're going into managed care, because money matters more. And not just money, but quality of care, making sure kids aren't going to 3 different primary care providers and 3 or 4 different behavioral health providers who aren't communicating. So it really is about quality of care and making sure there's continuity, that there's collaboration. So care management is important in that. It's always been important, but really important now. And so now if someone's in a standard plan, care management is provided through that standard plan. Either they've contracted with an agency that does it, or they have their own care managers. So let's say Sally, I think is who I had named the child that we were talking about. Let's say right now that she's in this United standard plan, she lives with her bio parents, not in foster care yet. Let's say she does have a care manager. She's a nurse care manager that is dealing with her asthma and making sure that behavioral health, that outpatient therapy is getting linked up or whatever. So when she enters foster care on August 15th, and that process behind the scenes is happening, the care manager from that United Medicaid, however that works with United Medicaid, and each of them does it a little bit differently, but they all have care management. They should be interfacing with the care management entities that apply to Medicaid Direct, and making sure that that care management entity knows that Sally has asthma. This is what's going on. Sally's linked to this doctor. Sally's linked to this provider for behavioral health. Sally's linked to, whatever. And they're also supposed to be doing that warm handoff to the LME-MCO as well, if it's applicable, if it's not something the primary care provider will be treating. So there could be that a foster parent interfaces with that care manager from United, and then interfaces with the one from either Community Care of North Carolina or Care Management for At-Risk Children, or CMARC, what used to be called CC4C for our little kiddos 0 to 5. Everybody's changed names, it seems like, and so it's just to make us all stay on our toes and keep up with the acronyms. But so that would be the way I would see that interfacing happen. But that's going to be generally speaking, because as we know, there's always that outlier that's like, oh my gosh, no one even thought that would happen. So like the scenario when I got contacted by one of the physicians who said, the young lady had been in foster care for months, should not have been chosen for a standard plan, and all of a sudden looks like she is when they were trying to do a higher level of care. I haven't heard any more examples of that. I'm sure that they're happening, but hopefully they're few and far between.
Yeah, so it sounds like to me that, because I know that I've had placements like that before, where they were on Medicaid before and they had a Medicaid number, and I tried to use that number, and the social worker was like, no, don't use that number. We need to get them a new number, a foster care number. And so if that never happened, or they never updated, that could be a problem now. So we did get some questions off of our Facebook page, and you've answered a lot of them, and you've already answered most of them. there are kind of two that I see that are left that haven't really been answered. And the first one is that one of our followers likes to use the same pediatrician for all the kids, provided that they are allowed to change from their current pediatrician to the one that they prefer. Will they be allowed to continue to use their preferred pediatrician? And it sounded like from what you said earlier, right now, yes, because kids are going to be in Medicaid Direct. In the future, maybe not, but as of today, they should, right?
Right. Generally speaking, yes. And so I thought about this question since I got those ahead of time. Thank you for that. So what I like to tell people, because in part of our work that we give education is about continuity of care. And so I have to say that the best practice is to keep a child in the provider they've been seeing for continuity of care. But we all live in reality, like Gaile's meeting with us in her car, because that's reality of a foster parent or adoptive parent or parent in general. And so that's best practice. But we know that children move out of county, so they can't go to their primary care. If they live in Raleigh and then they get moved to Buncombe County, you can't drive to Raleigh every time they need to go to the doctor. So we know that. We also know that even in Raleigh and Wake County, it's a big county, as are many of our counties in North Carolina, and there's a lot of options. And we have some foster parents who like to take all the kids to the same provider to try to get it synced up a bit, so that you're not on the road all the time. And so some counties do it differently. So some counties, and I think that this parent mentioned that if they're allowed to, if that's part of the protocol, because some DSSs don't allow that, some do.
Right.
So you got to follow your DSS protocol. But if your DSS gives that choice to the foster parents, then yes, they should be able to continue seeing, that provider. One thing I hear from the providers, because we meet with everybody, is, they have to make sure that they are getting records or something about these children, because if they don't know them and they just show up, sure, they can do some care, but for their ethics and everything of being a physician, they need to know something so that they're not blindly treating something or missing something with no records. And so that can sometimes be a sticking point of the time it takes to get records from the last place to the new place. And encouraging the DSSs to make sure that form that they should be filling out that gives some of that medical history to the new primary care provider. Because if the primary care provider stays the same, the kid's been seeing them at 5 and they've been seeing them since they were babies, then they don't need records from anywhere else, or they don't, or generally for primary care. And that health history form is not as important. But if it's a brand new county, brand new provider, then they have to have something. But so generally speaking, yes, on the Medicaid sort of side of things, yes, they should be able to change the provider, because if that provider takes Medicaid for their other foster children, then they would take Medicaid for the new foster child.
Okay, and then the other big question that I see that might need to be answered is, if your child is considered medically complex or behaviorally complex, it won't affect them? Wait, that's not a question. So I think what it boils down to with this question is, are therapeutic placements considered medically complex and or behaviorally complex? And I wonder if the answer to this is, it depends on the diagnosis.
Well, yeah, that they're absolutely considered medically and behaviorally it's behaviorally complex. And so that's an MCO, LME. That would be a, go ahead, Christy. Yeah, absolutely.
Yeah. So, and one thing that I've learned in my world of working for fostering health is, so the medically complex thing I can definitely answer. So medically complex in that they receive CAP-C, so Community Alternatives Program for Children. So your kiddos who have trachs or have services where a nurse needs to come in and do that kind of thing. A lot of those are on CAP-C. Those should have stayed in Medicaid Direct. Mm-hmm. Now, medically complex as far as having diabetes or having asthma or things like that, they probably would be on a standard plan unless they have the behavioral health needs as well. Behaviorally complex, it does sort of depend on that statement, or those two words, depends on diagnosis, services, that kind of thing. But the therapeutic part, then yes, that should be an LME MCO if they're a therapeutic level of care. but remembering, because it seems like the therapeutic foster care gets interchanged a bit of whether children are in DSS custody foster care in therapeutic level of care versus in therapeutic foster care or behavioral health needs, but their parents have custody and DSS is not involved at all.
Right.
Those kids, this doesn't apply to, because some of them may have other services besides may have other insurances, may not have Medicaid. They're not in that what's considered foster care. So why they're called the same things, I'm not real sure of the history of that, but I know that could be part of your membership is people who also have those placements, because some agencies have both of those private agencies have both types of children or children in those types of situations.
Yeah, good point there, Christy.
Yeah. So I always like to say anything I talk about has to do with DSS custody foster care, because all of our work has to do with that. And then I know that there's a whole nother population of kids who a lot of what we talk about probably should apply to them. They probably had some trauma. They have behavioral health, needs and all that. But like our kind of guidelines and our work is really focused on those kids in DSS. So that's what I know more about.
Yeah. And I think the last kind of question is this a good thing, right? Like the other kind of questions that we had were like, is it negatively or positively affecting foster parents? Is it going to expand or restrict access to services? Like, so overall, as somebody who's an expert, and maybe this is a bad question to ask you, and we can edit this out, but overall, do you feel like this change, and I'm talking about the change that happened July 1st, do you think it's positively or negatively affecting the foster parents on the ground, the foster parents who have placements in their homes? Do you think this is positive, or is this going to be a little bit more challenging?
So it is a complicated question. I think that I will give a bit of a politician's answer to a bit of extent, since this is recorded for other viewers. But so I think it's complicated. I think change is hard. And I think for people who haven't lived and breathed Medicaid speak for years, it was already complicated, or there was already a lack of knowledge. Besides, I have Medicaid, and this is what I do. I go to my doctor. I used to work boots on the ground with people who had Medicaid, and they typically, and this is a generalization, but they didn't know the nuances of it. I mean, I have Blue Cross Blue Shield private insurance, and I don't know all the nuances of it. I know the language of it. So if I wanted to read the handbook, I could, but I don't. Who does that? Who has time to do that? And so I read it when I need it. And so I feel like, and I live in that world and I speak that language. And a lot of our folks who either receive Medicaid that are adults or that are definitely children, and then foster parents who don't live and breathe in that world day to day, it's complicated and it's hard to understand. And so I think change is hard because especially when it's changing in different phases and different populations, and this one could be changing now or they maybe have not. And so that just gets to be a little bit like, whoa, what? How does this affect me? And so I think with that, it could seem negative because it's just complicated, and we get frustrated through when things are complicated because life is complicated enough. You want these children to get the services they need in a timely manner so they don't have to change placements again, and life is already hard enough. And so so it's complex. So I think that could be viewed negatively. I do think, though, for the general population of children who were in foster care up through June 30th, there shouldn't be a difference felt unless people are hearing this lingo. I think what might be complicated is those outliers who have gotten into the wrong plan and nobody knows it until it's time for that higher level of care. And hopefully people moved on that really quickly to get that changed on the Medicaid side so that child could get a higher level of care. I think that integrated care is a good thing. I think that not having things operate separately and having that continuity of care is good. I think it's complicated though, because behavioral health, IDD type world is very different from the physical health world, and combining those is just complex. I think that when change this big happens, it just is so many moving parts. And so, you know, when they started writing all this Medicaid managed care stuff, it was for that general population, and that for the general population of children that live in the home of their bio parents who have custody of them, that is easy in that there's not someone else who has custody of any sort of that child. And then there's also not resource parents. So there's not, you know, whereas there might be, you know, easiest scenario, it's a parent or parents who are together who have a child. More complicated if you have parents who are not together but have custody of a child. Then you throw in foster care where the complexities are higher, population is more vulnerable. You've got DSS involved, you might have bio parents involved. They have to be in some respects for consent or have to have court order. And then you've got resource parents. So we have you guys that it's wonderful, but it's more complex because you've got 5 different warm bodies of figuring it all out. And that messaging, making sure that everybody knows the part they need to know, because no one needs to be an expert in it as a foster parent, but they need to know enough to know where to go for help.
Right.
So
That's such a great answer to that question.
Yeah.
Yep. So, and I think it's good to know that the foster plan rollout for the managed Medicaid is coming out on July 1, 2023. And so when we get more information about that, and they're meeting monthly and they're making tweaks, I sit in on those calls and listen to them, and you know, and I'm just like, okay, yeah, we agree with that. No, you know, and we get feedback.
Yeah, and I do think about that plan because I think I didn't get past 2022 with the tailored plans, but so 2022, July 1st, 2022 to June 30th, 2023, standard plans will be in effect, tailored plans will be in effect, and Medicaid Direct will still be in effect. And then July 1st, 2023 is when the target is for that supposed to be statewide foster care plan. So that is when I think there will be one entity that has it all. So that will decrease that LME-MCO complication that we have now.
But that's way in the future.
I understand, but that's 2 more years from now. And so right now, so that's like, keep that in the back of your mind. And obviously Gaile attending those meetings, I'm on that work group too. And we want to make sure they're making that plan what it needs to be and not be what it's, you know, because once it's in plan, it's harder to change.
Right.
And what they did with that is they put out a paper earlier in the year outlining that plan, and the feedback they got led them to halt that because it was supposed to start in 2022. And they realized that we need to take this back to the drawing board and get more input, because the nuances for foster kids are just complex. They're just different than any other population because it involves every entity you can think of. It involves LME-MCOs, behavioral health, IDD, substance use disorders. It involves parents. If reunification is the goal for a lot of these kiddos, then foster parents have, or bio parents have to have some services in place, or how can they be successful, you know? And so it's just so much more complex. So I'm glad they're doing those work groups and getting that feedback and trying to find that common ground of what works best for this population.
Well, I just wanted to thank you, Christy, for taking time out of your schedule to talk with us and to kind of shed light on where we are right now with this Medicaid transformation, because it is such a hot button topic right now. And you go into some of these Facebook groups and everybody's an expert and nobody's an expert all at the same time. And it's for somebody like you were saying, I'm a foster parent. I'm not an expert in Medicaid at all. So hearing LME, I can't even say the acronym, the LME-MCOs versus like direct Medicaid direct, is all very confusing. So thank you so much for taking time out of your schedule to come and talk to us and just to help us understand what's going on so that we can, continue to be professionals and continue to provide as much care as we can to these children in this time where they're going through so much, and they don't need to know that we're,
Right.
ducks flapping wildly under the water and we're just like calm and cool on the surface. Right. So thank
Absolutely.
you
Well,
so
thank you for
much.
reaching
Yeah.
out to me. I'm glad to do that. And, that, like I said, that's what we do at Fostering Health NC, is to try to provide that, health and well-being. If it has to do with that, we're glad to talk about it and make sure to put some of those pieces together.